So welcome to the third and final part of Theory of Change for Complex Interventions, and my name's Mary de Silva, and in this part we're going to be talking about how you use theory of change as a framework for the process and the outcome evaluation of a complex intervention or of a health programme. I'm going to use a real example of a project to show how we designed an evaluation strategy for a complex intervention using a theory of change framework. So this programme was called PRIME, the Programme for Improving Mental Health, and it's a 5-country project whereby we worked in Ethiopia, India, Nepal, Uganda and South Africa, and in one district in each of those 5 countries we developed a mental health care plan which covered the treatment of depression, psychosis and alcohol use disorders and epilepsy, and we integrated treatment for these disorders into primary health care. So it's an extremely complex intervention happening in lots of different contexts, and in order to produce an overarching evaluation plan which could be used across all 5 countries, we developed first of all a theory of change which summarised how the intervention would work in all of these 5 countries. So this is the PRIME theory of change, and I think it shows the value of theory of change, that a programme that runs in 5 countries can be summarised on one A4 sheet of paper in a diagram. So the first exercise I want you to do is to look at this theory of change and circle the primary outcomes. So which of the boxes on this pathway are the primary outcomes, the long-term outcomes, which are what we're aiming to achieve with this programme. So if you just pause the recording for a minute and circle or think about which stages in the pathway are the primary, the long-term outcomes. And there you go. So the last 2 outcomes before the ceiling of accountability are improved outcomes for people with mental disorders treated by the programme and their families and carers. And then secondly, assuming that the programme is working for people, that there's increased effective coverage of evidence-based mental health services. So because we're working at a district level, we can say that this programme will be accountable for increasing effective coverage of mental health services in the districts in which we're working. Now the next thing I want you to do is to circle all of the outcomes on this pathway, which are the process outcomes. So the things about how the actual programme or the intervention was implemented. So pause the recording and have a think about that. And as you can see, I hope you've picked this up, basically every other outcome on this pathway is a process outcome. And this really highlights one of the benefits of theory of change, which is often when you do an evaluation, people focus on the outcomes. They focus on people getting better, and they don't focus on the process through which the intervention was implemented, which made people get better. And unless you properly evaluate the process, you won't understand the how and the why the intervention worked, and you won't understand why it worked in that context. You'll only know whether it worked or not. So the key thing about a process evaluation and about the benefit of using theory of change as a framework for your evaluation is that you find out what worked for whom, where and why. Here's a summary of the importance of having a good process evaluation. The most important thing is that if your intervention doesn't work, if your evaluation shows a null result, you need to be able to know whether this is because the idea was a bad idea and essentially the intervention does not work, or whether it was a failure of implementation. So was it that the intervention just wasn't implemented right? Perhaps not enough people were trained, or they were trained but they didn't have the right skills, or perhaps people didn't want to use the intervention because it wasn't acceptable. So by understanding the process through which the intervention was implemented enables you to interpret the results of the evaluation properly. It also enables you to measure or evaluate the pathways through which a successful intervention actually worked. So which bits of the intervention were most important, which bits of the intervention didn't seem to have an impact and could perhaps be dropped. It also allows you to document unintended consequences. For example, you might find that you're training a whole new load of health workers, and that means that other disorders aren't getting the attention that they once were because you're taking away human resources from a different area. Using the theory of change framework also enables you to understand how the social, organisational and political context influences outcomes, because you're recording throughout the process the context in which the intervention is being delivered in, and you're understanding at which points in the pathway the context might have an effect. And then lastly, all this information, understanding what worked for whom, where and why, is invaluable to aid scale up of any intervention, because you need, in order to scale something up, you need to know that it's acceptable and feasible. You need to know which are the active ingredients in an intervention which should be prioritised for scaling up, and which bits can be dropped. Normally when things are scaled up, they're also scaled down in terms of the intervention is made more simple. So you need to know which bits you can drop and which bits you have to keep. And lastly, it should give you some clues as to contextual differences. So were there particular things about a particular context which meant that the intervention worked in that context, which would make it unlikely to work in other contexts? So hopefully I've sold you all on the idea of why you need a decent process evaluation, and also why theory of change provides a great framework for that process evaluation. So I'm now going to go back to the prime theory of change and just take you through the actual evaluation that we did for prime, so that you can see how you can build an evaluation plan from a theory of change. It's a non-randomised evaluation in the 5 countries. It wasn't randomised controlled trials. We used a variety of observational methods to evaluate the whole of this pathway. So the first thing you do to develop an evaluation plan from a theory of change is to allocate indicators to every single stage in the pathway, as I showed you how to do in part 1. And then the second question is, how do you measure these indicators? So I'm going to take you through an example of that. So taking 2 of the outcomes in this pathway. Remember that this is a programme integrating mental health treatment into primary care in low resource settings. So we need the service providers, the people in the primary health clinics, to be able to diagnose people with mental health problems, and we need them to be able to treat those problems appropriately. And that means that the people with mental health problems are correctly identified and diagnosed when they turn up at facilities. If that doesn't happen, if we aren't able to correctly find people who've got mental health problems, then the whole programme won't work, because you'll be treating people who don't have problems, or you will miss the people who do have problems. So this is a really critical stage in the pathway. So the way that we chose to measure whether that outcome had been achieved was a study design which we called the Facility Detection Survey. And the research question it sought to answer was, does the mental health care plan, the MHCP mental health care plan, increase the correct diagnosis and initiation of evidence-based treatment for depression and alcohol use disorders? So the process we went through to get to that study design was our intermediate outcome that I've just showed you. The people with mental disorders are identified and diagnosed in facilities. The indicator to measure whether that outcome had been achieved was, we decided that a 20% increase in the proportion of people who are correctly identified and treated between baseline and after the intervention. So before we trained anybody, before we put our mental health care plans in place, we would measure how many people are correctly identified with depression by healthcare workers, and then after training and after the program's been running for a while, we would go back and do exactly the same study and measure whether that proportion of people correctly identified had increased. So the research questions stemming from that indicator are, what's the coverage of correct diagnosis in facilities? So what proportion of people are correctly diagnosed, and what proportion of people receive effective treatment? And the research methods which stem from that research question are this repeat facility detection survey. So we screen all of the people attending primary healthcare for depression and alcohol use. Those people who screen positive, we then follow them up to see whether they were correctly identified, diagnosed and treated by the healthcare staff. And we did that before we implemented the intervention and up to a year or more after we implemented the intervention. So that one research method measured 2 of our outcomes in our pathway. So now the next study design that we used was a cohort studies, and this measures a lot of the long-term outcomes, the primary outcomes. So basically, what treatment did people receive, and did that treatment mean that they had improved symptoms? So we had a load of research questions, which are kind of standard research questions really for a cohort. So did the between baseline when people were recruited into treatment and up to a year after treatment, did they have improved clinical symptoms and reduced disability? And then we also measured a whole range of secondary outcomes such as social functioning, economic status, healthcare expenditure, equity of access to and outcomes of treatment, experience of stigma and discrimination, etc., etc. In addition to those quantitative measurements, we also did qualitative studies on the people going through the cohort to ask about satisfaction with services, what they attributed any change in their outcomes to, so that we got some explanatory data to explain changes within the cohort. The third study design that we chose to use measured 4 of the indicators on the theory of change, and this is does the mental health care plan reduce the treatment gap for people with priority disorders? So overall, we wanted to increase access to mental health services across the whole of the district. So the only way that we could measure whether we'd achieved that was by doing a cross-sectional community survey. So we wanted to know whether people who screened positive for mental disorders had received any treatment in that district. And then a variety of secondary research questions such as the prevalence of depression, level of stigma and discrimination suffered, the costs and healthcare costs associated with help seeking, etc. So the way we did this was we screened a random sample of 1,500 people in each of the 5 districts in each of the 5 countries, and then we asked all of those 1,500 people a screening tool for depression and alcohol use disorders, and expected about 10% of the population that we screened to have those, to screen positive for those disorders. And then we asked those people a series of questions such as, have you ever had treatment for this? If you did, where did you go and how much did it cost? And then we also did exactly the same questions on a subsample of screen negatives, so that we had effectively a case non-case comparison. And we conducted this community survey at baseline before the intervention was implemented, and we're going to conduct it again up to 2 years after the intervention has been, the mental health care plans have been operating in the district, and we very much hope that the screen positives that we find in the community, a higher proportion of those people will have had access to treatment now than before we implemented our intervention. Now, if you look at the theory of change, you can see there's still quite a lot of outcomes which haven't yet been captured by our 3 study designs. So we did one more study design to cover effectively all the process outcomes, and we called this a case study. And the basic research question was, how well was the mental health care plan implemented in each of the 5 districts? And we looked at 3 different ways of measuring how well the mental health care plans were implemented. So first of all, we were very, very interested in understanding the quality of training and the quality of supervision and the skills that the health workers had, so that we knew whether they actually had the competencies to deliver quality mental health services which would enable people to actually get better. So we did surveys, pre-post training tests to assess competencies. We did observations of counselling sessions to test for the competencies of counsellors. We also tested the competencies of supervisors and looked at the frequency and the quality of supervision. Secondly, we did a series of profiles at the different levels of the health system. So we did profiles at the district level, where we effectively kept a log a continuous log of all the activities that happened in the district. So how many times did we meet with the district authorities, what budget's available for mental health care, for the mental health care plan, what was the level of engagement, were there any changes in the district's context, such as, for example, unfortunately the earthquake in Nepal happened at that time while we were implementing services in Nepal, so we tracked the different changes that happened in that community and in the health services in that community as a result of the earthquake, which had an impact on our ability to deliver the mental health care plans. We did the same thing at the facility level. So for each of the health facilities that were delivering mental health care, before we implemented services, we went in and we effectively audited them. So we said, how many people have you got here who work in mental health? What drugs have you got available? How many people do you treat? And then we went back and repeated that after we'd implemented services, so we could see what services were actually being implemented on the ground. And that's really the critical thing. And we do exactly the same thing in the community. So are all the interventions which are supposed to be in the community, are they actually really there? And are people attending support groups? Are the things that the mental health care plans say should happen, are they actually happening? And then the last part of the case study was the costing study. So, of course, critical information for any healthcare planner and any policymaker. So we recorded the cost of actually delivering each component of the mental health care plan. So how much did it cost to train people, to supervise people, to hold meetings with district health officials, etc., etc., so that we could get the total cost of implementing these mental health care plans. So this is the 4 study designs which we chose to measure in a non-randomised way the whole of the pathway for PRIME. Now clearly this is a very complicated study with 5 countries and 4 different research designs, and it's no denying it was a massive undertaking. And I wanted to show it to you as an example of kind of a very complex evaluation, and maybe that you can take bits of it. So you might do parts of the case study and a cohort study, for example, and maybe that would be enough to cover all of the indicators in your theory of change. But I really wanted to show you the range of different methods you can use to evaluate a program, and the fact that you do need a range of different methods if you really are going to understand the process of how and why and whether an intervention works. So the kind of end result of this process of developing a evaluation plan is that you effectively end up with a table where you list all of the outcomes of the theory of change map, and then you list the indicator which measures whether that outcome is achieved, and then you allocate a study design to measure that indicator. And as you can see here, one study design can measure lots of different indicators. But you need to make sure that every indicator on your theory of change is measured. Now, if resources are tight or there are logistical challenges, you might decide to not measure some of the indicators. So if you look at the top of your screen, there's an uncircled outcome, and that's the environmental, policy, social and political context of the district is monitored for modification of implementation. Now we are trying to measure that through the case study by recording events at the district and community level which affect implementation. But in reality, that's a very difficult thing to attribute causality to. So though we're trying, we haven't been able to do that in a proper way, because basically it would be so expensive and time consuming to do. So it's completely fine to not measure all of the indicators on your theory of change, but you should really try to measure the most important ones, the most important causal pathways that you think are happening. So once you've got your evaluation plan, then you can do interesting things looking across the whole pathway. So for example, we can merge data from the cohort study and from the costing studies in order to understand the cost outcome. So what is the cost of a one disability adjusted life year, one DALY improvement in somebody treated by the mental health care plan, which provides obviously very valuable information for policymakers, because they can compare that to the cost of a DALY in another health condition. We can also look at the results of the community survey and the cohort survey to see whether the effective treatment gap has been reduced. And we can also look across all of the study designs at the intervention intensity, so how well, effectively, the mental health care plan was actually implemented across each district. So which bits didn't work well, which bits did. And once you've got all of that data, then you create your final story of change. So you use the results of your evaluation to redraw the map to reflect the reality of what your intervention showed, of what your evaluation showed. So if a pathway didn't work, then you take it out of your map. If a pathway worked in a different way than what you thought it worked, then you would redraw the pathway to reflect what you actually found. And then that becomes effectively your description of what your intervention actually is. So you obviously need to analyse all of this data, and I think the thing to really emphasise is that the methods that you use for a theory of change driven evaluation are no different to the methods that you would use for any other evaluation. You use whatever methods you want, it's just you hang them on to this causal pathway framework. So standard qualitative and quantitative methods are absolutely what you would use depending on whichever research method, study design you chose. Now, there are some other more advanced statistical methods that you might want to use if you want to measure the actual causal pathways, so the strength of different causal pathways. So structural equation modelling, for example, is one type of statistical technique which might be very useful to see which causal pathway is the strongest throughout your programme. And then I've listed a variety of other types of analysis which you can look up. There's obviously not time to go into all of these different models in this presentation, but it's just to flag that there are some other types of modelling and statistical methods you could use to model the whole pathway. And once you've done your analysis, theory of change can help with dissemination. So it can give you an accurate description of the intervention that you actually implemented. That might aid political buy-in, partly because they've been involved in your project through developing a theory of change right from the beginning. So policymakers are obviously your key stakeholders that you'd want to have in your theory of change workshops. Perhaps that makes it easier to adapt to other settings because you have a realistic description of how an intervention works in a context and which bits are most important. So adapting it to other settings becomes easier. And lastly, it perhaps makes it easier to synthesize with other studies. So in meta-analyses, one of the common complaints is that programs don't adequately describe what their intervention actually was and how it actually worked. And having a standardized way of presenting a theory of change map, which describes exactly what your intervention was and how it worked, might make it easier for people to understand what you actually did and therefore to group similar studies together in a meta-analysis. So that concludes the session on how you use theory of change as the framework for your evaluation. And I just want to summarise really, remembering right back to part 1 when I presented the MRC framework for design and evaluation of complex interventions. This summary just takes you through the 4 stages of the MRC framework and shows how theory of change helps to strengthen the MRC framework. So first of all, when you're developing your intervention, theory of change can help this process by building consensus with stakeholders, designing interventions that aim to cause a real-world change that is agreed on by stakeholders from the community, and using that stakeholder engagement to embed the intervention within the context, and also providing a frame for any theory, any true theory. So for example, if you're doing a behavioural change intervention, you might have specific behavioural change theories which get inserted into the pathway as rationale for why you think doing, for example, counselling improves people's well-being. And the second real benefit is that using a theory of change workshop creates realistic expectations of the expected impact of the intervention. So I've had examples where the policymakers or the healthcare planners have said, well, that sounds wonderful, we want to, roll this out across the whole district and make a real impact. And then you say, well, that's wonderful, so now you need to pay for 50 more community health workers to deliver this program. And they suddenly say, oh, we can't afford that. And so you have to redesign your theory of change with them to reflect what's actually possible with the resources, and it sets people's expectations much more realistically In terms of improving or enhancing the feasibility and piloting stage of the MRC framework, then using a theory of change framework enables you to formulate research questions by showing where there are gaps. So what are the assumptions which you need to test to make sure the intervention works? What are the bits of the pathway that you don't have any rationale for, that you need to make sure you evaluate to provide new rationale for doing that thing? And then it improves the piloting phase because you're evaluating the whole of the pathway, and you can evaluate whether the project is kind of having an impact on short-term outcomes, and use that to inform the intervention design at a very early stage. So hopefully by the time you get through to the formal evaluation, you know you've got a programme that at least works in a pilot stage. In terms of the evaluation, theory of change enables you to have multiple pre-specified outcomes. So as you'll notice, our primary and secondary outcomes, there were quite a lot of them, but because you've pre-specified them in advance and you haven't data dredged once you've got the data, then that's a very good way of having hypothesis-driven outcomes. Very importantly, it combines the process and effectiveness evaluations into one framework. So instead of having a separate paper, high impact paper showing the results of the evaluation on primary and secondary outcomes, and then a separate paper which describes how the intervention was actually implemented, theory of change forces you to think of process and outcome together as one pathway. And it doesn't make any sense to talk about what the outcome of the intervention was without also describing the process through which the intervention actually worked. And thirdly, having this pre-decided causal pathway which you're testing, it helps to disentangle which parts of the intervention are most effective by explicitly measuring and testing each of those pathways. So instead of just measuring your primary and secondary outcomes, finding your intervention works and then hypothesizing why it worked, you're actually measuring throughout the whole process of the evaluation why and how it worked. And then lastly, in terms of implementing the intervention once you've finished your evaluation and hopefully you found a successful result, then you can, I think theory of change will help to improve the dissemination of the results of your project, because you have a powerful, simple visual tool which you can use with a diverse range of stakeholders to describe the intervention, to get local buy-in, and to show which active ingredients of the intervention need to be really emphasised. And as I said earlier, it might also help with synthesizing results from similar studies in systematic reviews. So that's the summary, really, of the whole of the three parts of this distance-based learning course. So in terms of more information, the Mental Health Innovation Network has got a lot of resources on theory of change, and it's not specific to mental health, it's all generic theory of change. This distance-based learning course is also on there. There's a paper describing how theory of change is useful for the MRC framework. There's detailed implementation guidelines if you want to run your own theory of change workshop. We've got a detailed guide of how you would do that. And also some blogs and other resources so that you can read around more about theory of change. So thank you very much for listening to all of these different parts, and I very much hope that you find theory of change a useful addition to your design and evaluation of complex health interventions. Thank you.